My presentation is about aggressive disease and aggressive myeloma, and it's based on what are the definition of aggressiveness in myeloma, which are several. There are some well-known prognostic features that mark the presence of an aggressive disease, such as the high-risk cytogenetics, for example, such as the high ISS or the high LDH levels. But there are other features that we commonly don't include in the baseline staging, but that can have a prognostic impact, such as, for example, the presence of extramedullary disease at disease presentation. And then there are other factors that we might consider in evaluating the aggressiveness of a disease, and that are related to the response to treatment. So the disease that is, for example, refractory to first-line therapy is an aggressive disease by definition, regardless of the baseline prognostic features that we can have. And another important factor is the duration of remission, for example, after first line, because patients relapsing early, and meaning early a relapse after a time of free from remission that is lower than expected with a specific therapy, is again a marker of aggressive disease. Well, I think that there are several definitions because the myeloma field is really under development. There are many biological definitions. So, for example, thinking about presence of FISH abnormalities, patients with deletion 17p are patients with a high-risk disease. In particular, if they have the mutation of the p53. So I don't think there is one single definition. There are several, and the field is really changing. I think that there is no specific therapy for aggressive disease, except that generally we use a multi-agent chemotherapy using a combination of drugs with different mechanisms of actions, and there are several that can be used. And also another important thing is to try to keep the peace in treating the disease, so one cycle after the other without too long intervals if they are not strictly necessary, to maintain the disease control, to increase the cytoreduction, using autologous transplant and maybe double autologous transplant in patients who are eligible, as an example. I think that we need still to work on that, because there are very, very few data that can, let's say, allow us to use a specific drug in a specific subset of disease, like, for example, the use of venetoclax in patients who are translocation 11-14 positive, but this is a drug still experimental. This is generally used in later lines of therapy. So this is an example of what can be precision medicine in myeloma. There are others. I think that the biology of the disease is so complex that there is, of course, a role for precision medicine, but we still have to work on it. I think that one is the strategy, the best strategy. We need to work on the best strategy according to prognostic features, but according to response, implementing the MRD evaluation in clinical trials to use it prospectively to see if we can base our treatment decision and our treatment intensity also on the response, and in particular on the MRD.